All rise for entry.
And everyone can be seated. Members of the jury, we're going to continue. Counsel, you may continue your report.
Dr. Obregon, I believe where we left off was talking about the HIPAA requirements for you as a psychiatrist.
Yes.
The HIPAA requirements do not limit your ability to obtain information.
That's correct.
Okay. Can I, Your Honor, if I may approach? I showed it.
May approach.
I'm going to approach you with what's been marked for identification as Defense Exhibit 3. Would you take a look at those pages? Do you recognize those?
They look like email correspondence between myself and Parker Schenecker.
Thank you.
Sure.
When you are treating a patient and you obtain information from any family members or outside sources, that information is information that you can use in your treatment of that individual?
It's definitely considered.
Okay. So HIPAA doesn't require you to exclude that information from your treatment of an individual?
Correct.
Okay. The information that Mr. Schenecker gave you regarding Julie Schenecker's condition and his observations, is that something that you took into consideration as far as your treatment of Ms. Schenecker?
Yes.
Okay. And was he able to give you information regarding his experience with her long-term,
Yes, I believe that was provided.
as well as his observations of her around the time of the fall 2010?
I believe so.
Okay. When Ms. Schenecker came in to see you on December 10th, 2010, your testimony was that she had moderate depressive symptoms?
That's correct.
Okay. And at that time, was that the first time that she's indicating to you the thoughts of suicidal ideation?
I believe so. I believe so, yes.
When she was there for that session, how long did you see her?
I believe it was at least 30 minutes.
Okay, so in that session you have 30 minutes as opposed to 20 minutes.
Correct.
When you completed that session with Ms. Schenecker, what medications were added, continued, or modified?
Lamictal was continued. Cogentin was continued.
You could speak up a little bit, I'm
Sure.
sorry.
Lamictal was continued. Cogentin was continued. Clonazepam was continued. And lithium was continued, and then Celexa was increased.
Where did the Celexa come from?
The Celexa was probably used as a adjunct to treat depressive symptoms.
Okay. How many medications did she have at that time to treat her depression or her depressive symptoms?
So the lithium, the Celexa, and the lamotrigine, basically.
What about treatment of any kind of psychotic features or antipsychotic medication?
So there were no formal antipsychotic medications.
Okay. When you saw Ms. Schenecker on December 10th, 2010, you did an assessment and decided at that point against or not to Baker Act her.
Correct.
Okay. Was there any communication that you had at all with Parker Schenecker after that visit on December 10th, 2010?
I don't recall.
When was the next time that you saw Ms. Schenecker?
According to the medical record, December 28th.
Your Honor, if I may approach.
Yes.
I'm going to show you the defense demonstrative exhibit for the month of December 2010. So Ms. Schenecker sees you on December 3rd. Is that yes?
Yes.
Okay. And then the last time was December 10th when she was having some suicidal ideation?
Mm-hmm.
Yes?
Yes.
Okay. And the next time is when?
December 28th.
What day of the week was that?
Tuesday.
Okay, so a little bit more than 2 weeks from the last time you saw her?
Correct.
On that day, December 28th, 2010, how was Ms. Schenecker doing as far as her depressive symptoms?
Appears to be about the same.
Which is?
Moderate.
Okay, so at that point she has moderate depressed symptoms?
Correct.
Yes, okay. What about the additional inquiry as far as feelings of helplessness, hopelessness, things like that?
So some feelings of helplessness and hopelessness, yes.
What does she tell you about her energy?
Poor energy.
What does she tell you about her mood?
Depressed mood. Or it's, so she wouldn't have said depressed mood. She would have mentioned that her mood, she may have had, her mood was down or her mood was not the best or that sort of thing.
What did she tell you about sleeping?
That she was sleeping more than usual.
And you have a word in here, and I'll spell it instead of pronouncing it. A-N-H-E-D-O-N-I-A.
Anhedonia.
What does that mean?
It's a fancy term for losing interest in the things that we had interest in before. So hobbies or pursuits or socialization, that sort of thing.
Do you have any idea of the actual verbiage, what she said to you that led you to put that in your notes?
I don't recall, unfortunately.
Okay. So those are your conclusions based on you speaking to her, interviewing her?
That's correct.
Okay. And on that day, December 28th, 2010, how long did you visit her?
At least 30 minutes.
When you spoke to her on December 28th, what did she tell you about suicidal ideations?
She had occasional thoughts of vague suicidal ideation.
Okay. So is it your opinion she's maintaining the same state from at least December 10th through December 28th?
I think that's a complicated answer to that question. It's not simply a yes or no answer.
Okay.
Is it okay if I
explain.
explain? Okay.
Sure.
So we look at things like compliance, like is she making her appointments? Is she engaging in therapy? And so it's, those things had definitely varied. But she was apparently making her appointments and engaging in therapy. And so we look at multiple factors. So I would say when you're looking at depressive symptoms, yes, about the same, but there are other factors that are involved in her overall condition.
As far as how she's representing to you how she feels for her depressed symptoms,
Correct.
they're maintaining from December 10th through December 28th, as far as what she's telling you.
Within that range, yeah.
You don't have any information at that time to represent something contrary.
Not that I recall.
Okay. Is there anything reflected in your notes that differs from what she's telling you in your observations?
I mean, the request for oxycodone and that she's not engaging in going to like support groups for being off alcohol. So again, it's not exactly the same. So it's a little bit different.
So she's not doing, at that point at least, alcohol treatment that you're recommending to her?
Correct. Yeah.
Is that yes?
Yes.
Okay, I'm sorry if you could speak up a little bit. I'm
Sure,
having a little
sure.
bit of a hard time hearing you.
No problem.
And as far as the oxycodone, what does she tell you about that?
I don't recall exactly, but it was a request for oxycodone.
She asked you for a prescription for oxycodone.
Correct.
Now, is that something that you did?
No.
Okay.
Yeah.
And you have information based on what she told you that she had 2 prior suicide attempts with an overdose.
That's correct.
And now for 2 sessions she's telling you that she has suicidal ideations.
So vague suicidal ideations, but yes.
Okay. And then once somebody tells you that they have suicidal ideations, you do the additional inquiries.
Correct.
And
Well, what additional inquiries are you?
do you talk to them further if they tell you I'm
Yeah.
having
Yeah.
suicidal thoughts?
Sure.
Okay.
Sure.
And then based on what she's telling you, that's how you're determining the feelings of helplessness, hopelessness, those types of
Yeah.
things.
Yep.
Okay.
Exactly.
And from December 10th to December 28th, are there additional factors that she's telling you at that time regarding her depressed state? As far as participation in things
Sure.
and
Yes.
sleeping and things like that.
Yep. There were changes.
What was her suicide risk at that time?
Medium, according to the assessment.
You talked to her again about a HIPAA release at that time?
Yes, I believe so.
And she doesn't sign one?
That's correct.
Do you do an assessment whether she qualifies at that juncture to be involuntarily hospitalized?
Yes.
And what was your determination on that?
No. She didn't qualify for Baker Act.
I'm sorry?
She did not meet criteria for a Baker Act.
When you speak to her and she's telling you about suicidal ideation, do you consult with your supervising psychiatrist about those things?
Typically after the appointment.
After Ms. Schenecker is gone?
Mm-hmm.
Yes?
Yes.
Okay. Do you ever have a supervisor come in based in her downslide in her mood?
Absolutely. Again, I just don't recall if that occurred during this appointment or not.
Okay. What can you tell me about the medication that you give her or prescribe to her on December 28th, 2010?
So lamotrigine was continued, cogentin was continued, clonazepam was continued, and lithium was continued, and Celexa was increased.
What do you do with Ms. Schenecker as far as a patient at this point whose mood has been not well for almost the entire time that you're treating her and is getting worse? She's asking you for oxycodone and telling you about her mood. When she leaves your office on December 28th, 2010, when are you advising her you want to see her again, since she's walking out the door?
Yeah. So 1 week.
Okay.
Yeah.
Your Honor, if I may approach. I'm going to show you defense demonstrative aid for the month of January 2011. Now, she sees you on December 28, 2011. When would be a week?
The 4th.
Okay, the
Of
4th
January.
of January. Do you see Ms. Schenecker on January 4th?
No.
Did she miss that appointment?
I believe so.
What do you do when a patient who is telling you about suicidal ideation misses an appointment with you?
So we fill out a form, and that form, because we do have no-shows for patients in the clinic. It's not an uncommon thing, or where they cancel. So I don't know if she no-showed, which is kind of like not calling ahead and canceling, or she canceled. It may have been that she canceled. But for no-shows, our policy is to have a staff member or myself will call and check on the status and send out a letter and try to make contact with the patient.
Did you have any contact with Ms. Schenecker after December 28, 2010?
So it looks like on January 13th.
What was your contact with her at that
Oh,
time?
I'm sorry, January 4th.
Okay.
Sorry.
What was your contact with Ms. Schenecker on January 4th of 2011?
I called regarding the canceled appointment and talked with her about rescheduling, and she basically declined. She was off her appointment for that day, later that day, but she declined. And she denied suicidal or homicidal plans or intent at present, and she denied psychotic symptoms, and she denied the use of alcohol or illicit substances right then, and denied side effects or adverse reactions, like mainly stuff out of the ordinary, because of course she had tardive dyskinesia at that time.
Based on that conversation, did you do a suicide risk assessment for her on January 4th, 2011?
So part of that narrative involves suicide risk assessment. So yes, it's not indicated, or actually it is indicated here, but we always kind of do suicide risk assessments, even with phone calls at times.
And what was your suicide risk assessment for Ms. Schenecker on January 4th, 2011?
Medium.
Were there any other efforts that you made to contact Ms. Schenecker or have her come in?
I don't recall, but at some point she was offered voluntary hospitalization and declined.
Is that reflected at all in any of your notes?
No, unfortunately. I don't know if it's missing or if it's, but I distinctly recall at some point, and I don't know if it's before this date or after this date, so I just don't recall that, but at some point I did offer her voluntary hospitalization, and she thought about it for a little bit and then declined.
But you have no indication from your records
No.
that you offered that to her?
That's correct.
Do you have any kind of form that you would fill out stating that you're offering a patient who may be suicidal to be hospitalized and they're declining?
No.
Is that not part of a standard procedure for a psychiatrist?
That's not part of a standard procedure for a psychiatrist to have a form for that. That's correct.
Now, when you talked a little bit earlier, when you testified earlier, you stated intense outpatient for Ms. Schenecker.
That's correct.
Was it your belief or your opinion at that time that Ms. Schenecker, through USF, was engaging in intense outpatient treatment?
When she kept her appointments, yes, because she was seeing myself and Beth Marsh, a therapist, so she was at times coming in multiple times per week. So
When someone like Ms. Schenecker, who's your patient, is depressed and has suicidal ideations, do you speak to Elizabeth Marsh to find out if she's making her appointments?
Again, I don't recall in this particular case.
Is there any note that you had any conversation with Ms. Marsh about her making any of her appointments?
I don't believe so.
The last time that you saw Ms. Schenecker, did you do a referral for some additional outpatient treatment for her?
I believe it definitely was considered, and it was considered, but there was no referral at that point.
When Ms. Schenecker spoke to you about her suicidal ideations, did you ever tell her at any time or talk to her about shooting herself?
I don't recall.
Did you ever tell her at any time that she would have to get the first shot off if she wanted to kill herself with a gun?
Absolutely not.
Is that something that you would say to anyone, any of your patients?
Absolutely not.
From the time you began treating Ms. Schenecker back in July of 2010, was there an ongoing issue about her alcohol use?
I believe so.
Okay. Was that something that she discussed with you?
It was kind of in the background, and at times it was minimized, I believe,
Minimized by?
by Mrs. Schenecker.
Okay. But it's something that you would have brought up with her and discussed with her?
I definitely would have asked about it for sure.
Alcohol use, is that unusual for patients that are diagnosed with bipolar 1?
No.
What about drug abuse? Is that something that's unusual for patients that are diagnosed with bipolar 1 disorder?
No.
Can you explain to the jury the term self-medicating?
So the term self-medicating usually refers to the use of illicit substances in order to reduce symptoms, but oftentimes, leads to problems because of using illicit substances and the effects of that.
Do you have any opinion about whether the use of alcohol or any other kind of narcotics or drugs would be used more with someone when they're in a manic state or in a depressed state?
I don't have that information.
Okay. When you were treating Ms. Schenecker, did she ever arrive at your office during her treatment under the influence of alcohol that you were aware of?
No.
Did she ever smell of alcohol when she was at your sessions?
No.
Would that be something that you would note?
Yeah, absolutely.
Has that happened before in the course of you treating
Absolutely.
patients?
Absolutely.
Okay, so if somebody came in and they smelled of alcohol, you would have put that on there?
Absolutely, or if they appeared sedated.
Okay. As far as the medication that she was prescribed, how would that be affected by alcohol use?
Could provide negative effects as clonazepam and alcohol act at the same receptors in the body. And so alcohol and benzodiazepines can have an additive effect as far as being depressants or sedatives.
What would happen to somebody if they drank alcohol and had those kind of medications?
They could make somebody sleepy or somnolent, sedated, and in worst cases, they could kill somebody.
Does it add to the effects of the medication?
It can.
Okay. And when you're talking about antidepressants, what does that do to someone taking antidepressants?
It makes it less effective.
Okay. I could have one moment. No further questions.
Cross-examination.
Thank you.
Good afternoon, Doctor.
Good afternoon.
As you indicated earlier, prior to actually meeting with Ms. Schenecker and providing formal care for her in July of 2010, you met with the attending physician and reviewed her entire chart to, for lack of a better phrase, get up to speed on her case. Is that fair to say?
I have to kind of mitigate that because I could have missed a page here or there. But yeah, that is the general procedure.
Well, I mean, you wouldn't have memorized every page, but
Right.
You want to get a good working understanding of the patient's problems and how you're going to try to deal with them. Is that fair to say?
That's correct.
Okay. You mind if I take a quick look at your file so I can make sure that we're looking at the same stuff and I don't ask you things that you don't have records on?
Sure.
I just want to see where you start.
And it starts actually
Oh,
over
it starts
here.
in the back?
So it starts right here.
Okay.
This is my position.
Okay. So you have reports from providers, other residents prior to you?
Not here, but yes, in our electronic medical record, that's correct.
When you first met with Ms. Schenecker on July 20th of 2010, one of the many things you spoke to her about was the importance of medication compliance. Isn't that correct?
That's correct.
The medication compliance means, among other things, taking your meds on time, showing up for appointments. not mixing the meds with anything that could be counterproductive, in so many words. Is that fair to say?
That's correct.
Okay. And you specifically talked to Ms. Schenecker on that very first meeting about non-compliance insofar as using alcohol with her medications, didn't you?
That's correct.
Okay. Because as you just indicated, in layman's terms, when you're dealing with a bipolar person who's taken all these meds, you throw alcohol into the mix and it can do a lot of bad things to that patient. It's bad for that patient's mental health. It could be, correct?
That's correct.
Okay. Including, it could make lithium ineffective. And is that correct?
Yes.
I can see you, doctor, but we have to make a written record. That's why I'm prompting you.
No problem.
Okay. So, if she's prescribed lithium, as she was in this case, and lithium was prescribed to reduce the suicidal thoughts, is that correct? Among other things.
Yes.
Okay. And she's told, don't drink, because if you drink, these drugs could be ineffective.
Right.
And it's on the patient to make sure they don't do anything counter-effective to their drugs.
Patient does have some responsibility for sure.
Because you can prescribe, but you can't monitor her actions every day of the week. Is that fair to say?
Yes.
Okay. And you told her on the very first meeting, when you're talking about all the bad things that can happen in mixing alcohol with drugs, you need to abstain from drinking. You can't drink when you're taking these meds, didn't you?
Yes.
And she refused. She said, I'm not going to follow that.
Yes.
Even though you had formally and fully advised her that by doing that, she's making a choice that could be adverse to her health.
Essentially, yes.
Doctor, you told me I could
No, just a moment,
ma'am,
ma'am.
2 oxys a
Just
day.
a moment. Take the jury out. You're reminded my prior admonitions.
All rise.
Your execs is in the courtroom. Let me explain. There'll be no outburst. Your lawyer's going to speak to you now. You do that again, I'll have you appropriately restrained. Do you understand? Do you understand? Talk to your client. We'll take a 15-minute break. Sir, you're admonished not to discuss your testimony or this case till you return to the stand.